we start? Shall we
Yes, you can start now.
Okay, good morning. Assalamualaikum. Okay, this morning we move on into acute leukemia topic. And as you have received my lecture notes, we're going to cover the clinical features, consists of sign and symptom of how an acute leukemia patient will be presented to you. A little bit on classification, FAB as well as WHO. FAB stand for French, American, and British, not the sabun fab that you use to wash your clothes. As well as an investigation for the ALL and AML, and a little bit of the principle of management. These are the learning outcome in which you have received before in your learning outcome books. Consists about 9 topics that you should be able to answer after we finish this task. Okay, this is the normal hematopoiesis in which all these mature cells develop from the hematopoietic stem cells, and then they become committed into myeloid progenitor cells and lymphoid progenitor cells. From lymphoid, and then they become the lymphocyte as well as myeloid become various cells. This is the normal hematopoietic stem cell. So for acute leukemia, by a definition, it consists of a group of malignant disorder, and it is characterized by uncontrolled clonal proliferation and leading to the accumulation of poorly differentiated blood cells in the bone marrow as well as in other tissue. So when the blood is full in your bone marrow, it will result in the replacement of the normal bone marrow elements. So the bone marrow is full of blood cell which result in the acute leukemia. So to simplify the classification, we have divided leukemia into acute and chronic, and this classified based on the cell types as well as the clinical cause. Cell type means this involve the lymphoblasts and myeloblasts, and the clinical cause is either acute or chronic. So the first lecture consists of acute leukemia, ALL and AML. ALL stands for acute lymphoblastic leukemia, whereas AML stands for acute myeloid leukemia. So from the name, ALL is coming from the lymphoid progenitor, whereas the acute myeloid leukemia, this is coming from the myeloid progenitor. So this is your normal stem cells committed into either lymphoid or myeloid, and depending on the leukemia, for ALL, the cell is arrested at the lymphoid progenitor cells, which give rise to lymphoblasts. So the cells are arrested here and keep dividing lymphoblast 2, lymphoblast 4, 6, 8 exponentially in the bone marrow. And the lymphoblast fails to mature. So you won't see normal lymphocytes anymore in the bone marrow as well as in the peripheral blood. And if the leukemia is AML, the cell is coming from the myeloid progenitor and become myeloblast. So from myeloblast, 2 myeloblasts, 3, 4, 5, 8 exponentially develop, and then you won't see any more mature normal cells in the peripheral blood. So this, you imagine this is your bone marrow. The myeloblast keeps on beranak pinak in the bone marrow, and it suppresses the normal development of cell. So your bone marrow, the factory is full of the immature cells. And once it fill up the bone marrow compartment, this immature cell might spill over into the peripheral blood. So whatever the remnants you see in the peripheral blood, the normal cell in the peripheral blood is the remnant from whatever left before. And then later on, little bit coming out into the peripheral blood, 1, 2, 3, and then from the bone marrow, you can see it fill up the peripheral blood. So the basic problem in leukemia is because of the uncontrolled production of the white cell, the immature white cells. And the fundamental defect is that the white cells are unable to mature. So by a definition, you can see that there is a presence of over 20% of blood cell in the bone marrow. So this is important for a definition, 20% of blood cells in the bone marrow, not in the peripheral blood. Means when you do a bone marrow aspirate and then you do a smear, you count the nucleated cells, and then for example, from that 100 nucleated cells, it should be more than 20% of blood cells, and then it qualifies for you to say the patient is having acute leukemia. Causes of acute leukemia is many, but most commonly is idiopathic. We don't know what caused it. And some studies show that it result because of the ionizing radiation. Some had shown is because it's due to the drugs. For example, the most commonly is benzene. Others like a virus, HTLV1, also is sort of some association to cause acute leukemia. And other than that is a hereditary genetic association. For example, Down syndrome is the most common syndrome that associated with leukemia. So you see that most of the Down syndrome patients, they have this tendency to have acute leukemia later on or during their course of life. Other than that, what causes acute leukemia? The other hematologic disorder, for example, first the patient is having a CML, myelodysplastic syndrome. So these are among the first hematological disorder the patient have. Later on, this condition might predispose the patient to have acute leukemia. So in this condition, we call the acute leukemia as a secondary leukemia, not the primary. The primary is this one. The primary is the hematological disorder, predispose the patient to have acute leukemia. So in this case, acute leukemia is secondary. And a little bit difference between ALL and AML. ALL most commonly is you can see in children and adult, whereas AML more common in adult. But age restriction is not a mandatory thing. Actually, this leukemia can occur at any age. But this is a little bit different in which you can gauge ALL and AML. And for ALL, the first peak at very early years of life, for example, at the 3 to 4 years of life in incidence, and then it keep on increase. The incidence keep on increases with age, in which the secondary peak ALL can occur in the elderly. So the first peak at the toddler, and then the secondary peak usually in the elderly. Male a little bit common than female, and it is curable in about 70% of children. And the most important difference ALL and AML is this one. This is ALL is the proliferation of lymphoblasts, whereas AML is the proliferation of myeloblasts. So this thing that gives the differentiation between ALL and AML. So how this clinical features, sign and symptom of a acute leukemia patient develop? First, like I mentioned just now, the leukemic cell or the blood cells proliferates in the bone marrow, and then when it's become too many, and then the blood cell, they fail to differentiate normally, but they further divide. This is uncontrolled division of the blood cells. It accumulates in the bone marrow. It suppresses the normal hematopoietic. It suppress the normal hematopoietic cells. What are the other two cell lineage? Is another thing is megakaryocyte, which gives rise to platelet, and then another thing is the erythroid lineage. Erythroid gives rise to red cell precursor. So white cell precursor is suppress these normal hematopoietic cells, and later on it leads to the bone marrow failure. And from there, leading to decreased production of the normal marrow elements, give rise to a sign and symptom. So what happened if there is a low platelet production and low red cell production, as well as there is no more normal white cell in the body. So this is how clinical features develop. First, the marrow failure due to infiltration. First, most commonly, they will have anemia. Why anemia? Because the blood cell already suppress the production of RBC. So RBC give rise to low hemoglobin. So low hemoglobin manifests as an anemia. So how anemia presented? Most commonly is pale. Patient looks pale and fatigue. Lemah, letih, lesu. Because of low HB. And then the second one, the blood cell also suppress the production of a megakaryocyte. Megakaryocyte which give rise to platelet. So the platelet low in the peripheral blood, what? Platelet low give rise to thrombocytopenia. So when the platelet low, common manifestation is either bleeding or even a spontaneous bruising. For example, like petechiae, and other than petechiae is gum bleeding. Other than that, bruises. This is the most common manifestation of thrombocytopenia. And then another thing is that they also might have a neutropenia because the blood cell fails to mature into a normal white cell. So neutropenia leads to infection, and other than that is a sepsis. Apart from marrow failure, acute leukemia patient also might have the blood cell infiltrate into other organ. These are among the most common infiltration. The blood cell infiltrate or goes to the liver, spleen, as well as lymph node. So they have lymphadenopathy, hepatosplenomegaly, or even the mediastinal masses. This is common in TLL. The blood cell also can go to the gum and give rise to gum hypertrophy. These features is common in a subtype of AML, M4 or M5 subtypes. It also can go to the bone, especially in children, or any other organ. This blood cell is very notorious, means it can go anywhere and everywhere. So these are among the common manifestations. Petechiae, purpura, because of due to low platelet, infiltrate into the gum. This is infiltration into the lymph node. These are among other common symptoms of leukemia. Other than that, it also can give rise to leukostasis. Leuko means the white cell, stasis, stuck. Actually, it can occur in any of the blood vessels. For example, in the CNS, can manifest as a stroke, and if in the lung, patient can have a dyspnea, difficulty in breathing. Other than this, constitutional symptom is also very common for patient in acute leukemia, in which consists of fever, loss of weight, and loss of appetite. So from the clinical features, you suspect the patient is already having acute leukemia. So how are you going to approach? How are you going to confirm? How are you going to diagnose a patient is having acute leukemia? How are you going to say that this patient is having acute leukemia? You need to do a lab studies to confirm. This is the foremost investigation, but full blood count is not a confirmatory test. Full blood count also won't tell you that this patient is having leukemia, because sometimes it gives you non-specific changes. For example, white cell can be leukocytosis. It also can have pancytopenia, or sometimes it can also having neutropenia. Full blood count also can show you that the patient is having anemia, low HB, or thrombocytopenia. So this is not a confirmatory, and what I can say, this is not so specific changes. Usually this is the first investigation we do. And then the next one is we move on into the peripheral blood smear, full blood or full blood film, full blood picture. They are all the same. So the smear, when you look under the microscope, you can see the morphology of the blast. For example, I give you an example of ALL. You can see this is a different type of lymphoblast in different subtypes of ALL. This is the classification, old classification, but we still use this name because this classification, it classifies the leukemia based on the cell morphology. So once you look this blood smear under microscope, this lymphoblast look different, and you able to classify whether they are L1, L2, or L3. I don't expect you to be able to classify like this. So this is a nice to know for you. For example, L1 is a very uniform blast. L2 is the heterogeneous, means the mix between the small and medium size of lymphoblasts, whereas the L3 subtypes, they are large and they have a blue basophilic cytoplasm, and they also have vacuolation. So these are among the different type of blasts in ALL. Once you look under the microscope or in the peripheral blood film, this is ALL. So these are the most common blood film that we receive. This is show you this peripheral blood film is leukocytosis, consists of just mainly of blood cells, and you can't see any normal neutrophils, and there is I can say that there is no lymphocytes in here, there is no monocytes whatsoever, eosinophil and basophil. So, but how are you going to differentiate that this is blast, whether this is blast or lymphocyte? They all look alike, but they are not the same. These are what I can say. This is lymphoblast. So how do you say the lymphoblast is actually, you look at the nucleus pattern of lymphocyte versus lymphoblast. The nucleus pattern in a mature lymphocyte is dense, lebih pekat, what I can say, lebih mature looking as opposed to this one. And if you can say, inside the nucleus, they have these small tiny things. This is what we call as a nucleoli. This nucleoli signifies the immaturity of the cells. Whereas in a mature lymphocyte, you don't have this small nucleolus inside the nucleus. So these are the two major things, how you're going to differentiate between whether this is lymphoblast or lymphocyte. And if you don't see that kind of lymphoblast, you might be able to see myeloblasts. Okay? Myeloblasts, for example, these are different types of myeloblasts that you can see in the peripheral blood. What's the difference between lymphoblast and myeloblasts? If you can see, the myeloblast is a little bit larger than the lymphoblast, and this nucleoli is a little bit more prominent than the lymphoblast. So this is what I meant, the nucleoli. This is the nucleoli. You can see this vacuoles thing, they are not vacuoles. These are small tiny thing inside the nucleus. These are the nucleolus, which indicate the immaturity of the myeloblast. So these are among the different type of myeloblasts of AML that you can see. These are very characteristic for the AML M3. For this one, you must know these subtypes, because this is what we call as a medical emergency. And the blood film is a very characteristic. It's not going to be the same as other myeloblasts. And these blasts, usually they are bilobe. There are two lobes. For example, this is very clear, two lobes of blast, and they have this faggot cell. And these are very characteristic in M3 because this is the type of medical emergency, and this actually faggot cells, they are actually consist of procoagulant, and because once they are released into the peripheral blood, they can induce DIC. And then another thing, this subtype is associated with translocation 15-17, and this translocation serve as a diagnostic and prognostic for this M3 subtypes. M3 we call AML M3 or acute promyelocytic leukemia. These are the other names. These are equal. Why we call that this is acute promyelocytic? This blast actually is the promyelocyte stage. If you learn the development of the neutrophil, this type of blast start at the promyelocyte stage. So that's why we also call as a acute promyelocytic leukemia, or in short as a APML. These are among other difference of morphology of AML. This is M4, this is M5. M4, M5 usually a little bit common. This kind they have gum hypertrophy presentation. This is M6, erythroleukemia. This is M7, megakaryocytic leukemia. This type of leukemia is a little bit rare. And then after the peripheral blood film, commonly we do the bone marrow aspiration and refine biopsy. So these are the position of patient. And then this is the Islam needle. We poke the patient at the PSIS, posterior superior iliac spine. And then we have to go through the skin, cortical bone, and then only then we go into the spongy bone or the bone marrow. From the bone is very, very hard. You can feel that there's a resistance because of the bone. You keep on until you can feel like a give away into a spongy bone, and then you aspirate. So when this bone marrow aspiration, so these are the purpose of the blood here. You send for cell morphology, and then you also send for cytochemistry. You also send for immunophenotyping as well as cytogenetic and DNA analysis. So this is the main common procedure to diagnose acute leukemia. So what you're going to see from the BMAT just now, this is the bone marrow smear. It is hypercellular, and the cell is either consists of entirely of lymphoblasts or myeloblasts, depending on the type of leukemia. And you won't see any other normal cell lineages because they are being suppressed by the blast cells. Is to show you the smear is hypercellular and consists of predominant blast and suppression of the other normal cell lineage. Again, this is also similar, hypercellularity of the bone marrow. And then the next one, you also send for cytochemistry. Cytochemistry is a spatial staining. It's either periodic acid shift, or in short we call as a PAS. This is positive in ALL, whereas cytochemistry for myeloperoxidase, usually this is positive for AML. However, later on when you go to your clinical years, when you go to housemanship, many hospitals don't do this anymore because the immunophenotyping, this test has been superseded by this cytochemistry. But just to mention to you, this cytochemistry is very good. You can differentiate whether this is ALL and AML. And then this is the gold standard diagnostic test we use currently in any hospital is the immunophenotyping. So from the bone marrow blood, you don't know whether the patient is having what type of leukemia, is either ALL or AML, you don't know. So you see, this is the cells that carries the antigen, the blood cells, because your cells and my cell, we have the surface antigen. And then in the lab, what we have is we have the antibody that can bind specifically to the antigen. So when there is antigen, antibody receptors binding, it gives rise to fluorescence, and it will be captured by the machine. And then from there, we'll be able to tell whether the patient is having myeloblasts or lymphoblasts. For example, like this one. We have all these antibodies. And then from the antibody antigen reaction, we will be able to classify whether the patient is having ALL or AML. For the ALL and then it further divide into is either B-ALL or T-ALL, depending on the cell markers, depending on the antigen that the blast carries. Stem cell markers are common, either in ALL or AML. They should be positive. Stem cell marker is signifies the immaturity of the cell, which consists of HLA-DR and CD34. ALL should be positive, AML also should be positive. And if the patient is having B-ALL, which is more common than the T-ALL, so the immunophenotyping is positive for CD19, CD20, CD20, CD22, which should be positive for B cell markers. If the patient is having T-ALL, this kind of cell marker will be positive. 2, 3, 5, 7 will be positive. So the B cell will be negative. If the patient is having AML, most commonly they will carry myeloid markers, consist of CD33, CD13, CD117, and other myeloid markers. But these are among the common markers we use in the lab to classify the acute leukemia. After we confirm with the immunophenotyping, usually from the bone marrow blood also we send for the cytogenetic. Cytogenetic mainly to prognosticate the patient, whether they are having a good prognosis or bad prognosis. I hope you know what is a prognosis mean. For example, if a normal cytogenetic karyotype carries a good prognosis, as well as if the patient is having hyperdiploid. But for hypodiploid, if they are positive for Philadelphia chromosome, this carries for bad prognosis. So these are mainly for to prognosticate the patient. However, in APL or APML, if you remember just now, the APML, the AML M3 subtypes, which associated with translocation 1517, this translocation we use for the diagnostic, as well as prognostic. For the others, mainly for prognosis. But for this one is to diagnose the APML. So this is just a summary slide consists of whatever the morphology, the immunophenotyping, as well as the karyotype. This karyotype is very advanced for you, but this is just to display that they can have any kind of karyotype, so many karyotype or many mutation. But among those, this is the common, this is the important karyotype, AML FAB-M3, bilobe, HLA-DR, and then the translocation 1517, or we call as a PML RARA. This is the most important among the rest. This is again the summary of ALL and AML, of how the morphology looks like, histochemistry, which one is positive, which one is the positive, cytogenetic, which one is having in the ALL, and then the immunophenotype. Okay, after you confirm that this patient is having acute leukemia, it's either ALL or ALL, and then you need to prognosticate the patient. For example, what are the prognostic factors that we use in the ALL or AML? For ALL, if the age is less than 1 or more than 10, is a bad prognosis. And then if the count is very high, is hyperleukocytosis, also is a bit, again, this is a bad prognosis. And if there is a presence of a Philadelphia chromosome, again, this is also bad prognosis. And for the immunophenotyping, TLL carries bad prognosis as compared to the BLL. And apart from that, this is the favorable diagnosis for the prognostic factors for ALL. This is to illustrate the difference of our old classification. This is mainly based on the morphology of the blood cells, as well as this currently WHO classification, in which they have incorporated the cytogenetic abnormalities into the classification. This is for ALL, is quite okay, quite nice, easy for you to understand. But when it comes to WHO classification of ML, there's so much more, because they have incorporated again the cytogenetic, the DNA or the DNA mutation into the classification. But if you see here, the FAB is still here. This is still part of the WHO classification. This is falls under the AML, not otherwise categorized. So if you look again, all this one is the equals to the FAB classification of AML. And then how are we going to treat this acute leukemia? The choice is depends or influenced by the type of leukemia, by the age of patient, and then it's either curative or palliative. This is the general principle. Usually we consist a specific treatment for acute leukemia, in which we use a combination chemotherapy or transplantation. And then other than that, it's just a supportive care therapy, for example, blood transfusion, antibiotic, nutritional support. Okay, for the ALL, we have a different phases of chemotherapy. First, we have to give induction therapy, intensification, and then followed by CNF prophylaxis and maintenance therapy. But for the AML treatment, it only consists two phases, induction and consolidation. So what does it mean? For the induction therapy, this phase is used to induce the absence of clinical evidence or lab evidence. So the first therapy, chemotherapy, is to kill off all the visible blasts in the peripheral blood, and then followed by intensification or consolidation. This phase is to eliminate the hidden leukemic cell, followed by maintenance, but maintenance only in ALL. This is just the chemotherapy. So when you want to give a transplantation, it's either stem cell transplantation or there's transplantation, bone marrow transplantation. For ALL, usually this is why we need to evaluate the prognostic factors for a patient. For example, why the prognostic factor is important? Because it relates to the treatment option. If the patient falls into a very good prognostic factors, this group of patients just might go into a normal path of the treatment. But if the patient is having poor prognostic factor, we might need to plan for a more aggressive treatment for the patient. For example, in ALL, the more aggressive is we might need to plan to give a blood stem cell transplant, because when the patient is having Philadelphia positive ALL, or whenever the ALL is refractory or in early relapse disease, whereas in AML, we might need to plan a transplantation after the remission of the first course of chemotherapy. So how this transplantation took place? First, you need to have, this is the patient, we need to find a HLA match donor, usually from the siblings. And then we give a GCSF to a donor to stimulate the production of stem cell. Then we collect the stem cell process it, and then we preserve it. We preserve. Why we preserve? Why we cannot give it straight away? Because we have to wait when the patient is at the most suitable time to give. Because we have to assess the patient, and we have to kill all the leukemic cells, in which you can imagine we need to empty bone marrow, in which we have to give a really chemotherapy to the patient, we empty the bone marrow, and then only then the patient is ready to receive the healthy stem cell from the donor, and then we transfuse into the patient. Okay, in summary, I'm coming towards the end of my lectures. In summary, clinical features, ALL and AML, you need to know the clinical features, the sign and symptom, how the patient presented. But before how the patient presented, it means how the sign and symptom is developed. And then the lab investigation, how you're going to differentiate between this ALL and AML. It's a little bit different here, especially the full blood picture, the smear, the cytochemistry, the immunophenotyping. The definite differentiation between the ALL and AML. You must know this thing. So again, this is just your learning objective. This is just to summarize for the FAB classification as well as their immunophenotype, their morphology. This is a little bit on the AML. Okay, just to show you, this is myeloblast. This is what I can say. This is definite myeloblast. And if you see this one, this is what we call AUROT. AUROT can occur in any type of AML, but most commonly, we expect to see AUROT in M3 subtypes. Usually, this is the kind of AUROT we see in AML M3. And when one AUROT like this one here and two here, we call AUROT. When it's so many like this one here, we call as a faggot cell. This is most commonly in M3 only, not in other subtype of AML. This is again bilobe and AUROT. So definitely this is M3 subtypes. Again, this is to show you the bilobe appearance of M3. And will you be able to say what kind of blast is this? What is this and what is this? This is lymphoblast. This is myeloblast. So in general, lymphoblast is smaller than the myeloblast. And if you can say that the nucleoli is not so prominent as compared to the myeloblast. Myeloblast is a little bit larger blast. Ample cytoplasms mean that cytoplasm is very ample as compared to this lymphoblast is a very thin rim of cytoplasm and very prominent nucleoli in the myeloblast. This is the end of my lectures of acute leukemia. Is it okay? Are you still alive?
Yes, Doctor.
Any question? Understood?
Understand, Doctor.
Okay, siapa tanya ni? Puravin Rush. Both AML and reduce the differentiation of leukemic blast into their cross-bending, hence lead to leukemia. So why in the slide is stated that it's elevated in full blood count? So why? Anybody can answer? Rush asking me, this leukemia leads to neutropenia and pancytopenia. So why in slide 19? We go to slide 19. So why in slide 19 white cell is elevated. So here, why I mentioned in full blood count, there is either leukocytosis or pancytopenia or neutropenia. Any of you can guessing the answer?
Doctor, is it because of leukemia? So what we know is that the white blood cells tu dia tak fully mature and functional. That's what we understand. And during the leukemia dia ada juga produce myeloblast macam tu, tapi dia tak fully differentiated, and that's why dia considered as pancytopenia, neutropenia. Walaupun dia sebenarnya produce tapi dia tak fully macam fully mature. That's why dia considered as neutropenia and pancytopenia macam tu.
Okay, you are right. Is either pancytopenia or neutropenia. This neutropenia ni because of the low neutrophil count. It's already suppressed the neutrophil. This one whereby the blast already suppress all the 3 cell lineages, pancytopenia. Right? Betul kan? Pancytopenia or neutropenia. Kat sini faham? Betul lah apa yang you mention tadi. But why this one? Raj is asking why there is also possibility of high white cell count here.
Mungkin sebab is uncontrolled white blood cells production.
Yes. So apa yang apa yang komponen yang give rise to this leukocytosis kat sini? Yes, it is uncontrolled production. So ini yang nak panah naik ke atas ni apa benda? What cell? What cell here?
Doctor, is it the lymphocyte?
The lymphocyte yang mature ke yang tak mature?
Tak mature.
Yes, you are right. So this leukocytosis is either blood cell, because you see that this full blood count is read by a machine. They just count the nucleated cells. This machine is not human, so it's a very poor. The machine cannot differentiate whether this is blast or whether this is a blast or this is immature cell or this is mature cell. So the machine counted wrongly of all the immature cells. Most likely is the lymphoblast or myeloblast into the white cell count. Because if you look into the principle of this full blood count machine, it has a different channel to count the white cell, the HB and the platelet. So whatever the nucleated cell, it goes into the white cell channel. So if you see, then here is the neutrophil might be low. The normal lymphocyte might be low and the other normal cell is low. But the blast is high in the peripheral blood. So it goes into the white cell channel. So that's why it gives rise to the leukocytosis. That's why we have to confirm this kind, what are these cells with the peripheral blood flow, whether true this is blast or not. Okay. Okay, Raj? Any other question? If not, I'll stop sharing and we can continue with our next lecture.